fgjtfvngecbyfvbugggfghiik.edu. And the reason that you can always email myself, Erica Williams, at erica.williams at illinois.gov. But all the screenings and particular questions go through U of I, but I also can answer those same questions. So a little bit about an overview about the program is that um, the university itself was just as passionate as we were to get an internship program into Illinois Department of Public Health. Now, mind you, we have an internship program, which um, is a paid internship program, but this is a non-paid internship program. And what we found that there were hundreds of students that wanted to work in Illinois Department of, wanted to work in public health, and why not have them work in Illinois Department of Public Health? So it was someone coordinating those interns together to be able to offer them to IDPH and get that internship going. And the one thing that we looked specifically at first was what educational programs. So we looked at the programs of healthcare. We looked at the programs for data analysis and public development, community engagement, and technology and improvement. That's where we started. We have, and you'll see in a couple of later slides, we've progressed so far from that since the internship has started. We will be completing a year of internship. Now, what I do want to point out is that interns can be with us one semester, 2 semesters. They could do just summer, or they could do all year with this program. So it's really the needs of that student, and they have the option to be hybrid because of the Springfield office. So IDPH and OSI partnership. So what we did was in our partnership, I talked about, we looked into like workforce development, what IDPH needs were, where we thought interns could benefit, and then who was willing to take on those interns. And as part of that partnership, we worked with the students at colleges and universities that provide meaningful, valuable work experience to the student in the field of the study of public health. And since we've launched this, if you look at the numbers here, applications in 2024, in the spring 2024, I'm sorry, was 83. If you look at it in summer, it was 52. And then the second, so we were able to place, I'm sorry, in the spring, we were able to place 16. In the summer, 16 college and universities, 30 graduate students, and 16 undergrad students. And then in summer, we went up to 176 applications, and then 119 applicants. And then we were able to place 51 college and universities, 51 from the college and universities, 65 graduate students, and 51 undergrad students. And then for this fall, we had 172 applicants. Applications were applications that we tried to fill was 141, but what we actually fill, applicants was 141. What we filled was 31 from college and universities. 81 of them were graduate students, and 59 of them were universities, undergrad students. So the hope for us is that we spread the word about our internship program, because those students need the hours, and we definitely have plenty of places they can work. Just some past things. So in spring 2024, these are some of the areas that took on interns. Lubia and community outreach took on an intern. We have Dr. Archie Barnes took on one for public health research. We have Dr. Archie Barnes took another intern on for COVID-19, the pilot program. Then we had our assistant director, Heather, took on one for administrative public health. And then we have Allison who took one on for government affairs. That so in spring of 2024, we actually had Sheila Baker took on administration support for health policies. Jennifer took on one for environmental health. Frida for data systems and community health. We have Dr. Artie Barnes again for public health research. Nicole Hildebrand for procurement. Samantha took on one for diabetes and that project. And then Tiffany Sanders took on one for health equity. And then for current interns for this fall, we have Evan for administrative law, Jennifer for environmental health, Bobby for EMS and highway safety, Dewan for health information internship, Lubia communications and outreach internship, community outreach, Hillary for regional infection prevention, Erica for property controls, Jennifer for Making Illinois Safety Plan internship, Noah for project management, Nicole for accounting, Noah for AI operations, and Nicole for event planning. So as you can see, the numbers are going up in IDPH and more people are getting exposed to the internship program. And that's what I'm here to do, is expose you guys to our program. So eligibility for our programs, any college or university student at any academic level, meaning undergrad, graduate, PhD student, PhD candidate, are eligible for our program, and they must remain in good academic standing. The types of internships we have, all interns will be non-paid. And just FYI, we are looking at, to be competitive, we are looking in the future, and it is talks about doing some form of stipend or payment through the schools, not through IDPH. And we are working on that. Interns can provide course credits based on intern academic institute requirements, can be solely for work experience, can be in person, can be remote. It's recommended if they are from the Chicagoland area and they're working with someone in Springville, hybrid, set work hours, and flexible work hours. The application process for the internship goes to Go University of Illinois EDU, and it could be found on the IDPH internship application. So it's on our website under HR. So that's where you could find the application, or you could go to Go University of Illinois. The slides will be provided, so you will have access to those. The university will screen candidates, interview and select interns on behalf of IDPH. The candidates will provide all necessary information for the applicant process, and they will the documents that's needed. So say, for example, Dr. Barnes is saying she specifically needs someone that is majoring in research. We would get all that documented, provided to show that. And then we'll inform, they will also inform interns of any requirements such as background checks, immunization records, drug screenings, any IDPH documentation that's needed. And then the responsibility of the supervisors will be introduce the intern to the the school will introduce the interns to the supervisors. IDPH on our end, we will also send a formal email on the introduction as well. The supervisors will schedule the orientation and coordinate the hours, the minimum and max they can work, and expectations. They will notify April Scholl to confirm start date and completion of onboarding tasks. She is in our HR. Conduct the required trainings. So we will conduct the required trainings and any other trainings that's needed. Plus, I saw that answer. I'll get to it in 1 second. Plus, our policies and procedures. Working with the students will get their credit hours documented and required. We will have day-to-day management of the interns. That will be the supervisor's responsibility. Regular meetings with the intern, provide general guidance, mentoring, training, and ongoing evaluations. monitor workloads, performance, and professional development, and notify April the completion of the offboarding. So we do have an offboarding they have to do just like our regular employees, and a survey that we would like interns to do because we want to improve our process as we go along. So those two things we do require to be done once the intern finishes their assignment. And then IDPH will not sign an I'm sorry, IDPH will not sign any agreements other than the standard one. So what I mean by that is we have a standard agreement with U of I, and U of I makes those agreement the agreement with the other universities. So to give you an example of universities that we're working with, Northwestern is one. Champaign is one. We have UIC. So we have a lot of universities partner with us, but the partnership is done through U of I, and then they inform us who the partners are, and then we connect. If at any point an issue arises with the intern, meet with the student to discuss concerns, reset expectations and timelines with them, and then send a recap email to IDPH interns at uofiillinois.edu. If issues persist, direct the student to set up a meeting with U of I and us in HR, and then we'll try to work through whatever the issue is. If the student continues to fail to meet expectations, notify us, and then we will terminate the process if we have to. How to request an internship. We will periodically in HR, we just had one, we'll do some lunch and learn informationals on it. But if you want to start the process now, because we are in the midst of going to select soon, you can, for the spring and summer 2025, so we want to take those candidates and place them exactly where they need to be. We're asking no later than Friday, November the 8th, to submit your request to IDPH intern/student request form. It's a smart sheet. If you need any further information, you can contact April or myself. April's email is up there, and mine is up there as well. Is there any questions? I'm going to stop sharing. I did see one come across. Let me go to the chat. Will computer equipment be provided? You know what? That is, we leave that up to do it. I know they did provide computer equipment for one intern this year, so they kind of screen how that works. Most college students have a computer, and Do It will set them up, but they will provide. I know we did provide one for one. So if needed, we will do that on a one-on-one basis. Omira?
Hi, Erica and team.
Hi.
Thank you for the presentation. So the reason I was asking, because they don't do it unless they change their policies. They didn't want us to use personal devices
Right.
with their stuff. So if they're able to do it, that's great. Number two, I'm interested in like getting 3 to 5 for the spring, and I'll submit my stuff. But I wanted to do more community health, and then also capture administrative side. Are there minimum hours that they need to do per week? I know you said a semester, the whole year, or one semester, but I need clarification on that.
Yes, so it depends on what their school hours are. So, for example, the one we have in our office, they work 9 to 1, and every other day they work 8:30 to 1:30. So it really depends on their school hours, but they're pretty much open for when they're doing their internship hours. So that is something that you can request specifically the hours you want, and then we'll work with to try to match those hours if that's something you want to do.
Okay. Second question, follow up, sorry.
That's okay.
You originally said 40 colleges, but then you mentioned Northwestern, UIC, and then U of I, and then the one in Springfield. My challenge I foresee is that someone from Champaign that would like to be an intern under me when I submit this,
Mhm.
it would be kind of far if I needed them to be in house.
Mm.
The other colleges that you mentioned, if there's anything close to Westchester, is that something that Anna could screen out for?
Oh, absolutely. She can, if your need is that you need someone in person, let's say 2 days a week, and they could be hybrid three, or you need them all days in person, that's what you're going to put in your information. Then Anna will screen for that. She will contact you directly and say, hey, we can't do this, or yes, we can do this.
Okay, thank you.
You're welcome. Is there any other questions? I thank you all. And again, I will provide the slides. So if there's any questions, my information is on there, and you please get in touch, and we'll see how well we can help you out or match up the perfect intern for you. Thank you, guys.
Thank you so much, Erica. Now I'm going to go ahead and pass it off to Lynette. And then as a reminder, I will email all of this stuff out in the newsletter that you guys will receive on Friday.
Alrighty, well, hello everybody. My name is Lynette Kale, and I'm also joined by Sue Johnson. We're both from the Office of Preparedness and Response, and we're going to kind of share some information about access and functional needs this afternoon, along with, and we'll send these slides out as well, along with some things that projects we're working on for the future. So can you all see my slides? My screen kind of went blank for a second, so.
Yes, we can see them.
Perfect. So just to kind of give you an idea of why this is an important area for us, we are, you can see on this first slide here that we are seeing a drastic rise in natural disasters. And we also know in public health, we're seeing a number of vaccine preventable diseases and reemergence of things we haven't seen in a long time. And so down here at the bottom is our 2024 rate of natural disasters in the billions of dollars. And this actually only goes through July. So it doesn't have Helene or Milton or anything that we're going to see this summer in there. But you can see this drastic progression of disasters over the last several years. And we know that people with access and functional needs in those disasters have the highest rate of rates of morbidity and mortality, that 1 in 4 people in the United States have a disability. However, access and functional needs includes more than just people with disabilities. So we're talking, a large portion of our population is impacted when we have these disasters. And oftentimes people have multiple access and functional needs or disabilities on top of each other. That people with disabilities are considered the largest minority group, if you weren't aware of that. And of course, racial and ethnic minorities with disabilities or access and functional needs face additional health and social and economic inequities. So it impacts a wide range of people. It impacts a large number of people, and we're seeing it more frequently as we see more disasters and more disease outbreaks. So when we say access and functional needs, and we say that it's more than just people with disabilities, what do we mean? We're talking about people who are individuals or communities who are disproportionately impacted by disasters or public health events. They could be a temporary access and functional need or a permanent need. And it interferes with their ability to access medical care, vital resources before, during, or after a disaster. So we're talking about, in this group, we're talking about children, people who are live in institutional settings, older adults, pregnant women, people with disabilities, people with chronic conditions, people who are take medications, who have limited access to transportation, who may be low socioeconomic status, individuals who are experiencing homelessness, and who may have limited English proficiency or non-English speakers. It also includes some other categories that you don't always think of, but people who may be equipment or power dependent, on medical devices, people who, like I said, may be don't consider themselves normally to have an access and functional needs, but they are in a temporary situation such as a pregnancy. And so they may come, move in and out of the access and functional needs category. For us, in the Office of Preparedness and Response, two of our main grants are the Hospital Preparedness Program and the Public Health Emergency Preparedness Program. And two of the big focuses for the next 5 years on those grants are partnerships in health equity, which is right up our alley. We've recognized over the years, and especially during COVID, that these areas were large gaps and areas for improvement as we move forward. And so they are being highlighted in the next 5 years in all of our grants. As far as health equity goes, HRSA defines it as the absence of disparities and avoidable differences among socioeconomic and demographic groups and geographical areas in health status and health outcomes such as disease, disability, mortality. And so we look at access and functional needs when we're planning as planning for the whole community, and understanding that by meeting the needs of the entire community and what that entire community involves, we can encompass everybody and everybody gets the best care. And one of the ways we're going to be doing that in the next year is to go through all the counties are going to have to do what's called a risk assessment. And that assessment will include access and functional needs and health equity in their assessment. So not only will they be looking for what disasters are they most likely to encounter or what their biggest risks are, but also who is the population impacted in their community. Do they happen to have a school for the deaf and hard of hearing, or do they have a large English as a second language population, or is there a population that may be at greater risk in their community, and to identify that in that assessment. And as we've kind of seen, and this is especially being highlighted as we look at the response from Helene, there are places where we often see areas of inequity in a disaster, whether they're being forgotten in planning or the alerts and warnings, for example, during COVID, and we told people to go to a website or to register online, and they may not be proficient in technology, as some of our older adults and things are, or may not have access to those things. So there's a variety of areas that we know to work on, but again, we're also looking for those special populations and needs of individual communities and addressing those as well. One of the ways that we do that is a simple 5 areas that we look at, and by addressing those main 5 areas, we encompass most of the needs, and that is we call it CMIST, and it stands for communication, maintaining health, independence, support services and self-determination, and transportation. So making sure we address each one of those in our plan. And then again, like I said, in our 2 main grants this year, these 2 grants run for 5-year periods, and this is the beginning of them. And they each have categories and priorities in them, but health equity and access and functional needs are running through both of them, through all of the capabilities these next 5 years. And so, and of course, we can't call them the same things because that would be too simple. So in the Public Health Emergency Preparedness Grant, they call it health equity, or people who are disproportionately impacted by public health emergencies, which is a mouthful. And Hospital Preparedness Program calls it communities impacted by disasters. So you may see those terms interchanged between the 2 programs. But as I mentioned, we're working through all steps of our emergency preparedness plans, and whether it's our risk assessments, our plans, new partnerships and gaps that we recognize from our previous disasters and pandemic, updating our data. And then as we move forward and we've made our plans, we've identified groups that we need to include, making sure that when we train for those areas and do the exercises next step, that we're including people with lived experiences and the community groups that represent them. So every step along the way, from the planning to the actual implementation to the testing of it, that we include everybody along the way. And then again, of course, for ASPR's the part that does the hospital preparedness program, and they call it the communities most impacted by disasters. And then same thing, we're going to work on our assessments, our plans, and our exercise with them as well. And this is just kind of a little, this is a committee that's statewide, and I just wanted to highlight this because I think this is a good example of something that can be taken from a statewide committee and made into localized groups as well, as a good format to follow. So this is the Illinois Access and Functional Needs Advisory Committee. It is under state mandate, and it is run under the IEMA and Office of Homeland Security. And what this group does, it meets on a regular basis throughout the year. It is made up of state agencies, community agencies, and then people with lived experiences as well. And this group meets to make sure that our plans, especially IEMA and the statewide plans, meet all of the access and functional needs. So like I talked about, making sure that our plans, include everyone and that we're testing those out and everything. This group specifically does that for the state IEMA plans. And so it's a good example of, something that could be made into a local group that we can model for other state agencies. But it's just putting it into a formal format to make sure that everybody is included, everybody's thoughts are and concerns are heard, and that we can see some real progress moving forward. It came out after COVID and some concerns about groups that had fallen in the gap during the initial response, and has made some good progress since then. So with that, I am going to stop speaking, and I'm going to have Sue explain a little bit more about some initiatives that we're looking at for expanding access and functional need partnerships in the next 5 years.
All right, thank you, Lynette. Hello, everyone. So with our resource preparedness initiative, that's still in development, we want to try and incorporate and capture the whole community. So our goal is to reach out to individuals who are most adversely affected by disasters and public health crises. So, of course, as Lynette had mentioned, people with access and functional needs, the unhoused, people who English as a second language, lower income individuals, rural and urban areas, those individuals who don't have access to healthcare, the internet, or traditional support systems. So that would also include people experiencing severe and persistent mental illness, people living in congregate housing and nursing homes, the elderly. Lynette had previously mentioned those. And I think you can go to the next page. So that's why we are really wanting to work with community health workers, community health navigators. We really are trying to reach out with community health partnerships of Illinois, the Illinois Medical Reserve Corps. So once I think you can go to the next slide. So once we really start getting enmeshed and working with these other groups, our goal is to really build relationships with these trusted leaders. and then once we establish that and feel comfortable, we can move forward with the pilot program, and that's really what we're trying to do with this initiative. And we're just starting out, so we have some resources, and hopefully you guys can take a look at them and share them with your colleagues. I think next page, I think we've got, so it's called your very personal preparedness inventory. It is kind of long, but it is in a digital format, and it really covers like what Lynette was talking about, the CMIST, the communication resource needs, maintain your health. It's a real, I was going to say elaborate, but it's a very detailed to really meet your needs or anybody's needs who can utilize this. And that's why we want to reach out with community health workers or the Medical Reserve Corps to get out and share these resources with them. And then there's another CMIS planning tool. And so when we share this with you, you guys will have access to that, and hopefully we can just kind of spread the word and get things rolling. So yeah, we're looking forward to any help that you guys can provide us, and if there's anything that we can help clarify, or if you have any individuals who we can meet with, that would be just a fantastic opportunity for us to get this shared throughout our state. So that's pretty much all that I have. Yeah, we are really wanting to engage with our local healthcare coalitions and community partners. So if there's any questions that you guys might have, I think that's about it on our end. That's about all I have. So thank you, everyone.
And here's our contact information. Really what we're looking for, like Sue said, is we're really looking this year to identify new partners, to include new voices in our planning process, and as we move forward into the training and exercise parts of our planning. And then, of course, our other goal is to educate the public more and other agencies about including access and functional needs in their planning, whether it's preparedness like it is in our field or if it's other programs, to be thinking of this in a wider capacity. And one of the resources was this class from FEMA that talks about including people with disabilities in disaster operations, but it's really good on explaining where that all comes from and who that includes. And it's just a good online, self-paced resource for people. And of course, as today and as the Minority Health pre-conference, things like that, we're always willing to hop on a call or, come do a presentation and help make those connections as we go forward. So I'm going to stop sharing. And of course, you guys will get these as well. But any questions for us?
All right. Well, I'm not seeing any. Myra, was your hand still raised from the HR section, or did you have a question on this one? Okay. And that.
No, I'm never took off my hand.
Oh no, you're good. I figured.
Much.
All right, so that wraps up our meeting for today. Just as a quick reminder to everyone, November meeting will be the third week of the month instead of the fourth due to Thanksgiving. And then just keep an eye out on your inbox for the newsletter that will have the recording of this meeting as well as all of the slide decks. If anyone is having any difficulties, if you have a government-based email that you have signed up with us and you're not able to receive the newsletter, please email the ambassador's email and I can email it separately to you guys in a different file. I know we've been getting some bounce back from a couple of emails, so just be on the lookout for that. But yes, I will let everyone go early today. Thank you so much for joining us for the meeting.